Good afternoon, students. The lecture is devoted to basics of anesthesia. The lecture consists of composed by 4 parts. First part of the lecture, general conception of the operative trauma and components of general anesthesia. At first, you should know what is anesthesia, anesthesiology. Basic definitions for the topic of the lecture. Anesthesiology is a science about protection of the human body from any operative trauma. Operative trauma is a dysfunction of organs and physiological systems as a result of surgical operation. Any surgery is a mechanical trauma, and what organs and systems suffer from the operative trauma at first. It's a CNS, central nervous system, endocrine system as a response to pain sensation, cardiovascular, respiratory systems as a response to redistribution of blood due to surgery, immune system in late period, in post-operative period, immune system suffer from mechanical damage of soft tissues and takes part in recovery of soft tissues, liver, kidney, and general metabolism. The components suffer from operative trauma because mechanical operation, surgical operation is a mechanical intervention accompanied with damage of soft tissues. Components of the operative trauma. Components of the operation stress. First is emotional excitation. The patient is expecting for surgical operation, worried about outcome of the surgery, and he suffers from emotional excitation. Pain, because many manipulations are very painful. Any preliminary manipulations preparing for narcosis is very painful. For example, catheterization of stomach, urinary bladder, veins, arteries, etc. Then pathological reflexes as a response to pain stimuli and overexcitation of CNS. Hemorrhage is a loss of blood due to incision and damage of blood vessels. Water electrolytic imbalance as a result of redistribution of water among liquid sectors of body, and damage of internal organs. I mean dysfunction of internal organs due to mechanical injury of their structure. Next definition is anesthetic state. Synonym is narcosis. Is a reversible pharmacological state characterized by the following components. Narcosis has components, many components. First of them is inhibition of mental perception. This is elimination of negative emotions and unpleasant impressions before an operation and loss of consciousness during surgical operation. Before any interventions, before beginning of the surgery, anesthesiologist must fall the patient into sleep, medication sleep, by using of medical drugs. Hyperreflexia is the second component of the narcosis. Is a blockade of all or separate kinds of afferent impulses. Afferent means that impulses that passes through periphery to the central part. Divided into two types of management: analgesia and neurovegetative block. Analgesia is a state characterized by absence of responses to the body to pain stimuli. In case of narcosis, we talk about central anesthesia, inhibition of activity of CNS parts participating in the receiving, modulation, and integration of peripheral strong stimuli as a pain. We can abrupt passing of impulses from peripheral parts to central, and brain CNS of the patient will not recognize afferent stimulation. They will not suffer from pain. Neurovegetative block is an artificial state directed to prevention of excessive neuroendocrine and vegetative responses to the operative trauma. Third component, muscle relaxation. And this is removal of muscle activity and stiffness, muscular stiffness, that can make difficulties for surgical team or surgical operation. Maintaining of an adequate gas exchange. For prevention of disorders of gas exchange, anesthesiologists must use AVL. This is abbreviation, means artificial ventilation of lungs. Tracheal bronchial intubation and oxygen therapy. Maintaining of an adequate circulation. This is maintaining of central and peripheral hemodynamics, cardiac output, volume of blood circulation, and peripheral microvascular resistance in the level enough to keep the patient alive. We should preserve the function of cardiovascular system because heart and vessels, the main system responsible for living of our body. For that purpose, they use cardiotonics, vasopressors, adrenal blockers, hemodilution, blood replacement therapy, and managed hypotension. This means directed to preserving the function of CNS and cardiovascular system. Metabolic control. The most often it is necessary to provide acid-base balance, water electrolyte balance, protein and carbohydrate metabolism. It's achieved by adequate balancing of energy, nutrients, consumption, water, electrolytes, substitution of hormones, and prevention of disorders of thermoregulation. Mechanism of general anesthesia. What is the mechanism of action of anesthesia? What happens with CNS, because CNS is a main target for action of drugs for narcosis. What happens with various parts of the CNS during falling into narcosis? Synapses and membranes of nervous cells are the most likely relevant sites of anesthetic action. Histological parts of the CNS, synapses and axons. These sites anesthetics produce various effects, including presynaptic inhibition of neurotransmitter release, inhibition of excitatory neurotransmitter effect, suppression of effection of neurotransmitters, enhancement of inhibitory neurotransmitter effect, blockage of voltage-gated sodium and potassium channels, and suppression of depolarization of nerve cell membrane. These positions stimulate suppression, reversible decreasing of functional activity of the CNS, because drugs, all drugs mentioned for narcosis, they suppress central nervous system in various variants, in different variants. Where do anesthetics work in the CNS? First is the cerebral cortex. This is the major site for integration, storage, and retrieval of information. And anesthetics clearly alter cortical electrical activity by means of factors of mechanism of development of the narcosis. Second parts, brainstem. Next parts, brainstem, hypothalamic and thalamic arousal systems. What anesthetics do in these parts? Anesthetics inhibit transfer of information through the brainstem. All ascending information passes through brainstem. Inhalational anesthetics, inhalated anesthetics block thalamocortical communication and produce loss of consciousness. And spinal cord. Spinal cord is a second large part of CNS. Spinal cord accepts and conduct nervous stimulation from peripheral and directs this nervous stimuli to the brainstem and brain cortex. The spinal cord is the site at which anesthetics inhibit purposeful responses to noxious stimulations, and through the brainstem, through the spinal cord, brain regulates all function of peripheral systems and organs. Classification of general anesthesia. General anesthesia is a narcosis can be classified into several groups. According to a source of CNS suppression, it means by what drugs, by what manipulations we can suppress of CNS. First, pharmacological narcosis caused by pharmacological agents is the most widespread type of narcosis. Actually, it's a generally accepted type of narcosis, multi-pharmacological narcosis. And electronarcosis as a variant of physical suppression of the CNS by electric current. It occurs due to CNS dysfunction with modulated electric current. According to the type of medication with drugs, inhaled narcosis, introduction of drugs through airways, through respiratory tract. Depending on the mode of introduction or gases, we can divide inhaled narcosis into mask type, endotracheal or endobronchial narcosis, and intravenous narcosis. All the drugs for narcosis can be given intravenously directly through cardiovascular system. According to the drugs used for narcosis, it means the number of drugs. If we use a single drug for narcosis, this is mononarcosis. A single or type of general anesthetic is used to suppression of CNS. If they use two or more drugs from the same pharmacological group of anesthetic, this is mixed narcosis. Several general anesthetics are used to narcosis simultaneously at the same time. And combined narcosis means that several general anesthetics in combination with other drugs from various pharmacological groups are used for CNS suppression. And according to phase of development of narcosis, it can be induction narcosis phase. This is phase from the start of narcosis to surgical stage begins, and maintaining of narcosis. This is phase in which the patient is falling into medication sleep and his vital functions are kept artificially with drugs, pharmacological drugs, and interventional manipulations with organs and systems such as artificial ventilation of lungs, stimulation of diuresis, or infusion therapy. Second part of the lecture, inhaled anesthesia. Inhaled anesthesia has components. First component is a medication sleep, means unconsciousness and amnesia. Second stage, analgesia. This is blockage of sensory responses to noxious irritations. Muscle relaxation, blockage of muscular activity and muscle tonus by interruption of nervous transmission at level of neuromuscular plate and neurovegetative block. This is prevention of pathologic response mediated by neurohumoral system. All these components, 4 components, can be achieved by inhaled anesthetics. We can use a single drug, for example, Halothane, for achievement of each of these components, but concentration of the inhalated anesthetic will be maximal and even lethal for the patient. And last component, support to physiological functions. It means adequate blood stimulation, cardiac activity, gas exchange, urinary output, maintaining of metabolism, and etc. We can use interventional manipulations, for example, infusion therapy, eye placement of central IV line, and drop by drop infusion of the solutions for maintaining of volume of blood circulation. For artificial ventilation of lungs, we can use ventilatory pumps for ventilation of lungs during surgery, for supplying of lungs with oxygen artificially by increased concentration in inhaled mixture. Anesthetics, what anesthetics we can use for first component of the narcosis. They can be gases and they can be fluids, volatile liquids. Nitrous oxide is a non-flammable and relatively insoluble gas, relatively insoluble in blood. The gas does not produce significant skeletal muscle relaxation and has proper analgesic effect. So we can achieve with nitrous oxide very good analgesia, suppression of CNS, but very insignificant muscle relaxation. It will be not convenient for anesthesiologist for intubation of the patient and not convenient for a surgical team to perform intra-abdominal operation. Gas mixture with oxygen should be used in maximum ratio 4:1, means 4 parts of nitrous oxide and 1 part of oxygen. Second drug, halotane, is the colorless lipid fluid, viscous fluid, well dissolved into lipids. We can vaporize the halotane in vaporizer. This is part of machine for preparing of gaseous inhaled mixture. Anesthetic effect appears in concentration of the halotane 1 or 2% in gas mixture, very low concentration. The gas doesn't irritate the respiratory tract, not cause bronchospasm, produce spasmolytic effect to larynx and bronchi, cause dilation of tracheobronchial tree, has very fast induction and recovery from narcosis, but has side effect. It produces cardiotonic and hepatotoxic effect, toxic for heart and liver. Sevoflurane has a minimal odor and pungency, good bronchodilator. This is gas. Sevoflurane is a gas, and can be used for induction to narcosis. This is up-to-date modern drug for narcosis, sevoflurane. In our hospital, most of anesthetic machines work with sevoflurane. And last example is xenon. Is inert gas, very expensive, but very tolerant to patients' physiological system. Difficult to obtain, so it's extremely expensive, but non-explosive, odorless, and thus can be inhaled easy with machines for narcosis. Mechanism of action. For beginning of narcosis, we should intubate the patient, or we can use mask type of narcosis. We can apply mask on the patient's face and give him gases for inhalation. With patient ventilation, the patient will inhale gas, narcotic gas. The anesthetic gas passes from the respiratory circuit to airways, trachea, bronchi, and alveoli. And that passes across the alveolar capillary membrane and dissolves in pulmonary blood, along the gradient of concentration and blood solubility. Cardiovascular system delivers blood with dissolved anesthetic to CNS, and CNS takes in the anesthetic according to the tissue solubility. CNS will saturate with gas by circulating blood. and progressively increased concentration of the anesthetic in the CNS cause progressively deeper stages of anesthesia. We can increase concentration of gas in anesthetic gas. Concentration of the anesthetic gas will be more strong, and deepness of narcosis will be more evident. For inhalation narcosis, we must use anesthesia workstation. This is a combination of devices and machines, electric and ventilators, for supplying of lungs with gases, with gases obtained from pipes or from cylinders or from vaporizers. The function of the anesthesia machine is to extract gases from the central supply and cylinders. Function is obtain the function of the anesthesia workstation. Receive the gases, then meter them and load them with anesthetic vapors, and deliver the gases to the patient for breathing. The anesthesia machine consists of first connections to piped oxygen, medical air, and nitrous oxide from a wall supply in the healthcare facility. Centralized supply of operation theater by gases or local supply from cylinders. Pressure gauges and regulators to monitor gas pressure through the system and protect the machine components and patient from excessive rises of pressure. In the piping system, the gases are present under very high pressure, and gauges and regulators reduce pressure till the pressure will be safe for the machine and for the patient's lungs. Flow meters for oxygen, air, and nitrous oxide. Flow meter is a device for measuring of gases, calculation, how many liters per minute the patient receives and how many liters per minute the doctor, anesthesiologist must give to the patient for adequate suppression of CNS. Vaporizer to provide accurate dosage control when using volatile anesthetics. For example, halothane is a liquid. The doctor put a few mLs of halothane into vaporizer, adjust the scale of the vaporizer for very precise dosing of the anesthetic vapors. And breathing secret. This is technical variant of connection between the workstation and lungs. As you know from your textbook, there are four respiratory outlines, breathing secrets: semi-open, semi-open, semi-closed, and closed. Nowadays, the most progressive and effective method of ventilation of lungs is a closed method. But structure of the machine must be complicated with scavenging system for reducing of concentration of vapors of carbon dioxide and concentration of water in exhaled gaseous mixture. After the patient begins to inhale the anesthetic, we can observe clinical presentation of the narcosis. Clinical picture of the narcosis means combination of signs, symptoms, and changes in functions, abnormalities in functions due to inhalation of anesthetic. We can divide of the anesthesia into four phases. First phase of analgesia. This is description of if the narcosis described by Gueddel. This is first description of narcosis, and all the anesthetics. Nowadays, all the anesthetics produce the same clinical picture of narcosis, but evidence of the various stages and phases differ and depends on chemical structure of the narcosis, of the anesthetics. Phase of analgesia, so begins in 3 or 8 minutes after inhalation of the anesthetic. and takes 3 to 5 minutes long. What signs we can observe in the patient's behavior? The patient loses his or her awareness. He becomes disorientated. In time, in environment, patient becomes talkative. He tries to talk to the doctor everything he wants to talk to him. The patient, some later, the patient gets a drowsy state. He becomes falling into sleep. And by the end of this phase, skin sensitivity is absent. Only superficial sensation is absent. Profound sensation is present. Profound sensitive function is present. Second phase of excitation takes 1 or 5 minutes long and characterized by psychic and physiological hyperactivity of the functions. The patient becomes very excited. Breathing becomes very deep and rare. Bradypnea. Blood pressure increases and all kinds of reflexes are enhanced, exacerbated. Both motor and talkative anxiety appears. The patient wants to run anywhere or talk to anybody. This is very short duration state, duration phase from 1 to 5 minutes, and after 5 minutes, phase of surgical sleep begins. We should divide the phase into 4 levels because division into levels is very useful and for maintaining of narcosis. Induction of narcosis takes first and second stage phases. Induction to narcosis takes first and second phase. Maintaining of narcosis takes third phase, phase of surgical sleep. So we must divide into levels. Deepness of narcosis depends on concentration of the anesthetic, and we can clinically recognize concentration of the anesthetic by levels of the narcosis. First level of eyeballs moving. This is medication, sleep begins. The patient falls into very deep sleep. He doesn't feel anything, he doesn't hear, see, or anything, and we can begin surgical operation. Hemodynamic activity is unstable. All reflexes and muscular tonus are kept. Eyeballs move chaotically and by the end of this level stop in the central position. When the patient's eyeballs stop in central position and corneal reflex disappear, it means we can begin surgical operation. Anesthesiologist approve start of surgical operation, surgical approach. The surgeon team can make incision. Second level or third stage is a level of corneal reflex. Muscle relaxation involves head and neck. The tongue may fall back and obstruct aperture of the pharynx. The patient may has hypoxia, acute hypoxia, so the doctor must intubate, anesthesiologist must intubate the patient before second level of surgical sleep. Hemodynamic activity becomes stable, corneal and pharyngeal reflexes disappear. Third level of the surgical sleep is a level of pupil dilation. Pupils gradually dilate and reaction to light disappears. The patient has mydriasis and his eyeballs stop in central position. Rhythm and depth of breathing becomes irregular. Tachycardia and blood hypertension begin, and muscular relaxation appears. Now please pay attention to muscular relaxation appears when tachycardia and blood hypertension appear at the same time. So, so mononarcosis is inadequate type of narcosis for surgical operation. And fourth level of surgical sleep is a level of diaphragmatic respiration, characterized by profound inhibition of physiological functions, paralysis of respiratory muscles. If the patient is not intubated, he may die due to absence of ventilation of lungs. And the patient shows very severe arterial hypertension. Very strong brain hypoxia begins in fourth level. This is toxic level of the narcosis. That level may transform into agonist state and death. And fourth phase of awakening, is characterizes with reverse development of all clinical symptoms listed above to the reverse direction, and the patient to recover from narcosis. If we will reduce concentration of the anesthetic, the patient will awake from narcosis. If we will increase concentration of the anesthetic, the patient will fall deep and may die due to intoxication. Okay, take a break for 10 minutes. In 10 minutes we will resume our lecture. Okay, let's resume our lecture. Part number 3, combined general anesthesia. As was mentioned above, we have components. We must distinguish components of the anesthesia. Pay attention to this slide. For each component, we have a specific pharmacological drug. Medication sleep and unconsciousness state plus amnesia. We should use non-inhalation anesthetics. They suppress consciousness very good, but do not produce good anesthesia or muscle relaxation. We can use them for suppression of mental activity only. Second component, analgesia, blockage of sensory response to pain. We should use non-inhalation anesthetics in combination with non-opioids and opioids. Opioids are drugs for suppression of pain activity, pain sensation. They produce very specific effect. They suppress pain. Muscle relaxation. This is relaxation of striated muscles. We must use depolarizing and non-depolarizing muscle relaxants for relaxation of muscles. And neurovegetative block. We can use neuroleptics or ganglion blockers. For each component, we should use a specific pharmacological group. This is combined narcosis. Combination of drugs from various pharmacological groups in their average non-lethal, non-toxic concentrations for incubation into adequate general anesthesia. And support to physiological functions, the same means as for inhalation anesthetic, infusion therapy, artificial ventilation of lungs, and oxygen support. Pharmacokinetics and metabolism of intravenous anesthetics. Intravenous drugs must be given intravenously, directly into cardiovascular system, and after they touch the bloodstream and spread in CNS, organs and tissues, they produce central and peripheral manifestations of narcosis. Intravenous anesthetics exert their primary sedative and hypnotic effects through an interaction with the inhibitory gamma-aminobutyric acid neurotransmitter system. Neurotransmitter system GABA is the principal inhibitory neurotransmitter within the CNS, inside the CNS. When the GABA receptors are activated by non-inhalation anesthetic intravenous drugs, transmembrane chloride conductance increases, resulting in hyperpolarization of the postsynaptic cell membrane and functional inhibition of the postsynaptic neuron. Lipid solubility facilitates diffusion of the IV anesthetics across the cellular membranes, including the blood-brain barrier. Most of intravenous anesthetic agents are eliminated via hepatic metabolism, followed by renal excretion of more water-soluble metabolites. What drugs we can use? Names of drugs we can use for routine non-inhalation anesthesia. Thiopental sodium barbiturates from the group of barbiturates is a commonly used barbiturate for induction to narcosis. it has a moderate side effect. It produces lymphotonic effect that is wide danger of laryngospasm and bronchospasm. We should use premedication before induction with thiopental sodium. Propanidine, analgesia and anesthesia is good enough. Rapid awakening and recovery of mental activity and muscular tonus, low toxicity, produces hypotension and tachycardia but irritates endothelium and can cause phlebitis. Because route of medication is intravenous, we should use large veins for supply of cardiovascular system with propanidine to avoid of peripheral phlebitis. Hydroxybutyric acid. The drug doesn't produce analgesia, no analgesia, absolutely no analgesia. Suppression of CNS, suppression of consciousness only. Has low toxicity and prevention of brain hypoxia and durable recovery of narcosis. The drug is very useful for operation on CNS, trepanation of skull and operation of CNS because the hydroxybutyric acid protects the brain tissue from hypoxia. And ketamine produces CNS depression, it causes very strong analgesia and amnesia, but produces hallucinations, very strong hallucinations, and elevates BP and increases of pulse, tachycardia and hypertension. The ketamine is contraindicated if the patient has pre-existing hypertonic disease or insult in analysis. Clinical use of intravenous anesthetics. What part takes the intravenous anesthetic in the combined anesthesia? First function is induction and maintenance of narcosis. Barbiturates and propofol are the most commonly used intravenous drugs administered to induce the anesthesia. For maintenance of anesthesia, we will use practically any hypnotic in particular doses, in average doses, by droplet infusion or by bolus instillations. Sedation. Propofol has been evaluated for sedation during surgical procedures and for patients receiving mechanical ventilation in the intensive care unit. The patients in critical state or in the postoperative period that need to be ventilated artificially, we can use propofol for sedation in the out of operation theater. And for analgesia, for example, ketamine produces a dissociative state of hypnosis and analgesia. The action of ketamine on opioid tolerance and hyperalgesia combined with the direct analgesic activity has led to its use in chronic pain stress. We can use relief pain by repeated injections in the treatment of cancer pain, chronic peripheral and central neuropathic pain, phantom and ischemic limb pain after amputations, fibromyalgia, complex regional pain syndrome, for example, post-traumatic neuritis, or visceral pain and migraine in neurology. Second part of the component is neuromuscular blocking drugs by relaxation. Neuromuscular blocking drug is the drug causes isolated relaxation of muscles, striated muscles, due to blockage of neuromuscular impulse transmission. In the modern anesthesiology, clinical importance have peripheral blockers, which block neuromuscular impulse transmission in the neuromuscular junctions. Classification of the blocking drugs according to mechanism of action. They can be non-depolarizing and depolarizing, and according to duration, they can be short duration agents, the elimination half-life of approximately 5 to 20 minutes, and long duration agents, the elimination of half-life of approximately 1 or 2 hours. We can use various different neuromuscular blocking agents in different phases of narcosis. It depends on induction or maintaining of the narcosis. Indications for use of neuromuscular blocking drugs: muscle relaxation for the best narcosis. Anesthesiologists must use the neuromuscular blocking drugs for providing of adequate narcosis. The main goal of neuromuscular blockage during induction of anesthesia includes paralysis of the vocal cords and muscles of the jaw. It makes trachea intubation more easy and safe for the patient. It produces convenient intubation, prevents laryngeal injury and vocal cords damage, and relaxation of the respiratory muscles, particularly the diaphragm, and allows controlled ventilation, very good, and adequate artificial ventilation of lungs. Muscle relaxation for the best surgical technique. Anesthesiologists should provide best conditions for performance of surgical operation by surgical team. Paralysis of the abdominal muscles and the diaphragm is often required intraoperatively, particularly during abdominal or laparoscopic surgery. It gives more convenient and gentle manipulations with tissues and organs of abdominal cavity and thoracic cavity. It's low risk of iatrogenic complications, damage of internal organs by mistake, and it provides adequate operative exploration. The surgical team has very good ability to explore the affected site more precisely and perform the surgical maneuver with best quality. Mechanism of action of the depolarizing agents. Depolarizing and depolarizing agents, they have different mechanism of actions. Neuromuscular depolarizing agents produce their block by binding to and activating the acetylcholine receptors of the motor end plate. End plate is a part of muscular fiber that touch to axon directly. This is distal part of neuromuscular junction. They cause depolarization by opening channels, just like acetylcholine does. This causes repetitive excitation that lasts longer than the normal acetylcholine excitation. And the constant depolarization means stimulation and triggering of the receptors keeps the end plate resistant to activation by natural acetylcholine. Therefore, normal neuron transmission to muscle cannot cause contraction of the muscle. Anti-depolarizing or non-depolarizing agents do not depolarize the motor end plate. They prevent depolarize of the end plate by natural acetylcholine. They produce the effect by competitive blocking the binding of acetylcholine to its receptors of the end plate. A decrease of binding of acetylcholine leads to a decrease of its effect and neuron transmission to the muscle, and less likely to occur. Clinical use of neuromuscular blocking drugs: where and when we should prescribe the muscle relaxants. Depolarizing drug, succinylcholine. The drug depolarizes postsynaptic receptors for 7 to 10 minutes long, and this drug involves induction to narcosis to facilitate tracheal intubation and excellent intubation conditions within 1.5 minutes after the induction. Non-depolarizing drugs, for example, rocuronium, pancuronium, or vincuronium, bind with acetylcholine receptors on postsynaptic membrane for a long period of time, from 30 minutes to 2 hours. And these drugs should be used for maintenance of narcosis when the surgical procedure exceeds 1 hour. We can use them for maintaining of narcosis. The component of combined anesthesia is analgesia, deprivation of the CNS with pain stimulation. We should use opioids, are the vital part of providing the analgesic component of anesthesia, especially total intravenous anesthesia, because drugs for inhalation or non-inhalation anesthesia do not produce sufficient loss of pain. The analgesic effects of opioids arise from their ability to inhibit directly the ascending transmission of nociceptive information from the spinal cord, dorsal horn, and to activate pain control circuits that descend from the midbrain to the spinal cord dorsal horn. So, opioids block ascending neuroconduction and descending effectors. Analgesia results from complex interactions at a number of sites in the brain, spinal cord, and peripheral nerve, and involves both mu receptors, first and second types, special targets for opioids is a mu receptor. At the cellular level, exogenous opioids produce their effect by altering patterns of interneural communication. Receptor binding initiates physiologic functions resulting in cellular hyperpolarization and inhibition of neurotransmitter release. Opioids produce analgesia, drowsiness, changes in mood, and mental clouding. These are side effects to analgesia. And nowadays, the widely used naturally occurring opioids, morphine, and synthetic opioids, fentanyl, sulfentanyl, alfentanyl, and remifentanil. The most strong drugs are synthetic opioids. They produce very good analgesic effect. For example, fentanyl has effect 400 times more than morphine. It's a very strong drug and suppress very strong pain stimuli. Where can we use opioids in anesthesiology? Opioids is a pre-medication part. Opioids are used alone or in combination with sedatives or anticholinergic agents as a pre-medication. It's a pharmacological preparing of the body for main narcosis. Aim of opioid pre-medication is to provide moderate sedation and analgesia before narcosis to make induction more easy. And as a part of narcosis, we can use them. Anesthetic induction is usually achieved by combining a loading dose of fentanyl with a sedative hypnotic, most commonly terpental or propofol, and a muscle relaxant. Induction to narcosis means combination of hypnotic, muscle relaxant, and an opioid. And during maintenance of the analgesia can be achieved with nitrous oxide. For example, nitrous oxide and oxygen, combination of nitrous oxide with oxygen, low concentrations of inhaled anesthetic agents, and additional fentanyl, boluses of fentanyl. What happens with respiratory system due to induction to narcosis? Muscle relaxation happens, and all respiratory muscles are striated, so they will be paralyzed due to injection of pharmacological drugs. How to support of the gas exchange? By special manipulation, means artificial ventilation, lungs and respiratory support. General anesthesia is associated with various effects on the respiratory system, including the loss of airway patency, obstruction, loss of protective airway reflexes, cough and vomit reflex, and hyperventilation or apnea. Therefore, one of the fundamental responsibilities of the anesthesiologist is to establish airway patency and to ensure adequate ventilation and oxygenation of lungs. The airway management refers to the practice of establishing and securing a patient's airway. The airway management is composed by the following techniques. We can use pre-oxygenation before induction for narcosis, ventilation via mask, for example, for induction of narcosis, and tracheal intubation, gas exchange while maintaining of narcosis. What is a pre-oxygenation? With the induction of anesthesia, hypoxemia can quickly develop, and as a result of hyperventilation or apnea, in combination with decreases of functional residual capacity attributable to the supine position, muscle paralysis, and the direct effects of the anesthetic agents themselves. Pre-oxygenation, the process of replacing nitrogen in the lungs with oxygen, provides an increased length of time before hemoglobin desaturation occurs in the patient with apnea. Pre-oxygenation is typically performed via a face mask attached to either the anesthesia machine. To ensure adequate pre-oxygenation, full concentration of oxygen in gaseous mixture must be provided at a flow rate high enough to prevent rebreathing, 10 to 20 liters per minute, and no leaks around the face mask must be present. To accomplish pre-oxygenation, we use tidal volume ventilation through the face mask for 3 minutes, which allows the exchange of 95% of the gas in the lungs. And head-up position has been shown to improve the quality of pre-oxygenation in the patients. Mask ventilation. This is a non-invasive technique for airway management that can be used as a primary mode of ventilation for anesthetic of short duration or as a bridge to establishing of a more definitive airway prior to intubation of the trachea. Mask ventilation is not only used to ventilate and oxygenate before conditions for tracheal intubation have been achieved, but it is also a valuable rescue technique when tracheal intubation proves difficult. The technique for mask ventilation is dependent on two key elements. First, maintenance of a seal between the face mask and the patient's face, and unobstructed upper airways. The airways must be practicable for air passage and should be sealed very tight pressure of the mask to the surface of the patient's face. The mask is usually held with the left hand. This is one-handed technique, with the thumb and index finger forming a C around the collar of the connector. The third and fourth digits on the ramus of the mandible, and the fifth digit on the angle of the mandible. The thumb and index finger are used to produce downward pressure to ensure a tight mask seal, while the remaining digits provide upward traction of the mandible to aid with airway patency. The right hand is free to provide manual ventilation if needed, or to regulate any parameters on the anesthesia workstation. The effectiveness of mask ventilation should be ascertained by observing for chest rise, exhaled tidal volumes, pulse oximetry, and capnography. Because of a reduction of muscle tone as a result of general anesthesia tissues fall backward under the influence of gravity in a supine patient and can absorb the upper airways. So to maximize airway patency, mask ventilation should be performed with maximal atlanto-occipital extension, overextension of head, in combination with placing of air conductor or displacement of the mandible to oropharyngeal airway. Oropharyngeal airways are the most commonly used. This is plastic air conductor. Should be inserted into mouth cavity, and the function of the air conductor is elevation of tongue and opening of the entrance to larynx for passaging of air. Intubation of trachea. After pre-oxygenation or after induction to narcosis via the mask, the doctor must provide a very reliable connection of the machine for ventilation with patient's airway. For that purpose, he should insert tracheal tube. And the tracheal intubation is the gold standard for airway management. It establishes a definitive airway, provides maximal protection against the aspiration of gastric contents, and it allows for positive pressure ventilation with higher airway pressure than with face mask. The tracheal tube has obturator. This is inflated cuff. Before intubation, the doctor should use direct laryngoscopy. Absolute indications for endotracheal intubation are if the patient is requiring pharmacological muscle relaxation, patients with a full stomach or who are otherwise at high risk of aspiration with gastric content or blood, patients requiring lung isolation during surgery, for example, due to endobronchial intubation, and patients who will likely need post-operative ventilatory support into active care unit. Equipment. The laryngoscope is a handled instrument consisting of a blade attached to a handle containing a light source. The curved blade and the straight blade are the two basic types of laryngoscope blades. In pediatrics, the most preferable direct blade of the laryngoscope; in adults, curved, more convenient rather than direct. And specific technique composed by 4 parts. The first part, opening of the patient's mouth, inserting the laryngoscope blade and positioning of the laryngoscope blade tip just above the epiglottis, applying a little force and exposing the glottis, and inserting a tracheal tube through the vocal cords into the trachea. 4 steps. Confirmation of endotracheal tube placement. We anesthesiologists must be sure that the tube placed between vocal cords and inflated cuff obstruct the trachea below the vocal cords. For this purpose, the doctor must use several maneuvers. Once the tracheal tube in place, the laryngoscope is removed from the mouth. The tube cuff should be inflated, and the patient is manually ventilated while the tube is manually held in place. Endotracheal placement can be determined by confirmation of chest rise during inhalation during pumping in the air into the lungs. The patient chest should rises. Visible condensation in the plastic tube means presence of the exhaled air with water vapors in the tube. Equal breath sounds bilaterally over the chest wall, and lack of breath sounds over the epigastrium. The doctor must auscultate the patient chest for estimation for revealing of respiratory sounds bilaterally, and large exhale tidal volumes and appropriate compliance of the residual bag during manual ventilation. ventilation. And the most important and the most objective indicator is presence of a normal capnogram. It's a waveform of carbon dioxide on operative monitor, an anesthesiologic monitor, for the presence of at least 3 beats. After their cremation, the endotracheal tube is in place. The doctor should secure the endotracheal tube to the patient's head or neck. Once the proper depth of the endotracheal tube has been determined, the tube should be secured in place to prevent movement and inadvertent endobronchial intubation or extubation. So the tube must be in place. The most common method is to tape the endotracheal tube to the skin of the face. When the tape cannot be used, such as in the case of severe tape allergy in the patient or extensive facial burns, a surgical mask may be tied around the back of the head to secure the endotracheal tube. Other methods that may be used for intraoral or facial surgery, for example, including suturing of the tube to the skin of the cheek. This is an invasive method of fixation in the tube. Take a break for 5 minutes and we will resume final part of our lecture devoted to local anesthesia. let's resume the lecture. Local anesthesia. Definitions of the fourth part. Local anesthesia is any technique to induce the absence of sensation in a definite part of the body while the consciousness is present. This is regional anesthesia. Local anesthetic is a drug that causes reversible local anesthesia and loss of nociception. Nociception is a CNS reaction to certain noxious stimuli that triggers a variety of physiological and behavioral responses and usually results in a subjective experience of pain. And route of administration of the drugs is a mode in which a local anesthetic can be given into the body. Local anesthetics can abolish sensation by topical application, injection near peripheral nerve endings and major nerve trunks, or installation within the epidural or subarachnoid space. Types of the anesthesia. Local anesthesia. Topical anesthesia is a blockade of receptors of skin or mucous membranes. Infiltration anesthesia is a blockade of nerve endings and thin nerves inside the tissue mass. And conduction anesthesia can be discussed in two types: peripheral type, blockade of peripheral nerves and plexuses, and central type, blockade of spinal roots within the subdural space. This is epidural anesthesia, or within the subarachnoid space. That is spinal anesthesia. Classification of local anesthetics. Nowadays, there are two groups of anesthetics: aminoesters and aminoamides. Aminoesters, novocaine, procaine solution, can be used for infiltration anesthesia or conduction anesthesia. Depends on concentration of the drug. Low concentrated drugs with weak solutions of anesthetic can be used for infiltration. Strong concentrated drugs for conduction anesthesia. Tetracaine in various concentration, approximately the same, 0.25 or 2% of solution can be used for peridural anesthesia. And drugs from second group aminoamides such as percaine, xylocaine, mesocaine or ultracaine. They are used for conduction anesthesia. Xylocaine solution can be used for surface anesthesia. Other drugs for conduction anesthesia or central conduction anesthesia or peripheral conduction anesthesia. Mechanism of action of local anesthetics. Solution of the drugs are deposited near the nerve and their molecules penetrate of the nerve sheath, intrathecal group. Local anesthetic molecules then permeate the nerve's axonal membranes and accumulate within the axoplasm inside the neural cells. And binding of local anesthetic to the sites of voltage-gated potassium channels prevents opening of the channels and bind to the channel spore and occlude the pore path for potassium ions also. So, two mechanisms of action: blockage of voltage-gated potassium channels by preventing of opening, or mechanically by blockage of the pores with molecules of anesthetic. During one set of local anesthesia, impulse blockade is incomplete, but further impulse inhibition produces good anesthesia. The degree of nerve blockade depends on the local anesthetic concentration and its volume. A minimal concentration is necessary to effect complete nerve blockade, and the sufficient volume is needed to suppress the regeneration of nerve impulse or a nerve fiber. We should use adequate concentration for blockage of potassium, voltage-gated sodium channels, and we should give enough amount of anesthetic for suppression of regeneration of impulses after primary suppression of channel activity. Characteristics of the methods of anesthesia. Topical anesthesia can be used prior for the most superficial manipulations. It is achieved by application of the anesthetics to skin or mucous lining. Anesthetics touch to superficial nerve receptors and produce very superficial anesthesia, skin anesthesia or mucous anesthesia. Topical application of local anesthetics to the airway, eye and skin provides sufficient anesthesia for painless performance of mild anesthetic and surgical procedures such as tracheal intubation, intravenous catheter placement or dural puncture. Or in dentistry, topical anesthesia is a preliminary part for conduction anesthesia by injection of strong anesthetics near the nerve. As example, we can discuss usage of xylocaine solution in various concentrations. Pharmaceutical application of xylocaine can be in the following forms. Solution we can use for anesthesia of pharynx or tracheobronchial tree or nose. For intubation before examination in otorhinolaryngology or in dentistry. In form of jelly, we should place the anesthetic solution into urethra before catheterization. We can apply a small portion of anesthetic jelly on the urethral catheter and insert the catheter in penless mode to the urinary bladder for emptying of the urine. In ointment form, we can use for anesthetization of skin or mucous membrane or rectum before examination in pathology. Viscose also can be applied into oropharynx in form of suppositories, rectal suppositories for anesthetization after surgery in pathology, or in gynecology in form of aerosol for suppression of noxious stimuli from vagina, or from stomatology, in stomatology for anesthetization of lingual mucosa. Infiltration anesthesia. Infiltration is a tight packing of tissue mass with anesthetic solution with appearance of anesthesia of this particular space. Clinical use of infiltration anesthesia. For example, for diagnostic biopsy, in minor surgery for excision of small benign tumors, for example, lipoma, in minor operations, in superficial operations, non-cavitary surgery, for example, for repairing of hernia, and in case when narcosis is danger to life of the patient, we can use local anesthesia in combination with drugs for maintaining of vital functions of the patient, for example, with sedative drugs, with drugs for stimulation of cardiac activity, or etc. Technique of the anesthesia. First, anesthetics should be injected intracutaneously, forming a citric peel mass along the following incision. When you mark the operation field with a line, which will be incision, you should anesthetize the skin along this line until the intracutaneous injection, until the citric peel appears. Then, after that, you should stick a needle into subcutaneous fatty tissue through the anesthetized portion of skin and give additional load with the anesthetics subcutaneously. Distance between injections should be from 2 to 3 centimeters. After the plenty superficial infiltration, you can cut skin and fatty tissue up to aponeurosis. These two spaces will be anesthetized and you can perform incision of soft tissues, partially approach. You can perform approach to the affected site partially, from skin to superficial aponeurosis. Then we should prick the aponeurosis with a needle and start the tight infiltration of the subaponeurotic anatomical space with your anesthetic. And after that, you can dissect aponeurosis and manipulate with profound anatomical structures such as peritoneum, pleura, or mesentery, layer by layer. So, essence of the infiltration anesthesia is a layer by layer anesthetization and layer by layer cutting of anesthetized layers of portions of skin. Principles of infiltration anesthesia was designed by Professor Vishnevsky, and there are 5 principles. First, use a large volume of weak anesthetics. To increase the volume of anesthetized area, we should use a lot of anesthetic. But to prevent intoxication, we should use weak concentrations. Second principle, tight infiltration of soft tissues with anesthetics. For good penetration of the drug to even small nerves, it should be injected into the tissues under pressure. Layer by layer injection. The drug must be injected layer-wise along the layers. In the following direction: skin, subcutaneous fatty tissue, under the superficial fascia, inside the facial compartments, inside the muscles, inside the serous coats, and internal organs if you operate on internal organs. Fourth principle, anesthetization of facial compartments. Infiltration of facial compartments gives good anesthesia to all nerves and tissues of the same compartment because fascia prevents diffusion and leaking of the drug outside of the compartment. And last principle is a hydraulic preparation, anatomical preparation. It means nerves, vessels and ducts become more visible due to presence of transparent anesthetic solution around them. We can differentiate them more clearly. And peripheral conduction anesthesia. This is regional anesthetic procedure which inhibits conduction in fibers of the peripheral nerves. Peripheral conduction anesthesia occurs due to peripheral injection of the anesthetic compound around the nervous trunk or around the nervous plexus. The zone that innervates by the nerve will be anesthetized also. Conduction anesthesia manifests with loss of sensitivity and motor activity because fibers composed by sensitive and effective nerves. And sensation disappears in the following order: temperature, then pain, and later tactile sensation. The anesthesia achieves by a small volume of strong anesthetics. Anesthetics should be injected as close to the nerve as possible, practically endoneurally. You should place your needle just near the nerve and inject the anesthetic, make the lower of the anesthetic just in the perineural space. Clinical variants of conduction anesthesia. We can anesthetize various peripheral nerves. The most often we can anesthetize digital nerves. This is anesthesia by Omers Lukashevich. Intermetacarpal spaces, also it's an anesthesia. Blockade of intercostal nerves. This is intercostal anesthesia. And femoral osseotic nerve blockage for operations of lower extremities. And we can anesthetize brachial plexus by Kulenkampff technique for operation of upper extremity. Central variant of conduction anesthesia is epidural anesthesia. This is blockage of roots of spinal cord by installation of anesthetic compounds inside the epidural space around spinal cord between periosteum and dura mater. Indications for peridural anesthesia are traumatologic and orthopedic operations of lower extremities, lower abdominal and pelvic surgery, and cesarean section. Mechanism of action of the anesthetic, of the anesthesia. Anesthetic diffuses through intervertebral foramens along peridural space and penetrates through spinal roots sheath, giving segmental paravertebral block. It manifests with analgesia and paralysis, loss of muscle power in lower extremity. And so the central nerves, these are spinal roots, will be anesthetized. We will be able to perform any operations proximally to place of anesthesia, for example, amputations, resection of any tumors on lower extremities, operations on joints, for example, replacement of knee joint or hip joint, or we can perform vascular and endovascular operations and open vascular operations on arteries, for example, prosthesis of femoral artery, or combined venectomy in patients with vascular diseases. So this is the end of the lecture. So my lecture is finished. If you have questions, you can ask me in the chat. If you have no questions, the lecture is finished. You can